begin. So you may have just received information that the webinar today is being recorded. So that's a nice reminder for me to remind everyone that it is being recorded today. So if, for example, you would not like to be seen for your own privacy, then please keep your camera off. So thank you very much for joining us today. So this is the first webinar of the series hosted by the World Transplant Games Federation Research Initiative. So the World Transplant Games Federation, if you don't know, is an organisation that hosts the World Transplant Games, but it also has a mission to help promote physical activity for organ transplant recipients. So recently this goal has led to setting up a research initiative, of which we currently have two chairs. So that's myself, Gareth Wiltshire at Loughborough University, UK, and Anders Billström in Halmstad University in Sweden. As part of this initiative, we hope to hold webinars like this for every couple of months. So the webinar today is being recorded, so if you prefer not to be seen, then please keep your camera off. We are very pleased to welcome our speaker today, Dr. Matt Wallen from Flinders University in Adelaide, Australia. It's late in the evening for him, so we are especially appreciative of his time. So Matt is a lecturer in exercise science and clinical exercise physiology in the College of Nursing and Health Sciences at Flinders University. He's also a researcher in the Caring Futures Institute, Flinders University, and an adjunct research fellow at Federation University, Australia. His main research area involves investigating the effects of exercise in individuals diagnosed with chronic medical conditions, including solid organ transplant candidates and recipients, and people living with and beyond cancer diagnosis. So today, he'll be talking to us about exercise and physical activity before and after liver transplantation. What exercise and physical activity before and after liver transplantation, what we know and what we can do, and where to next. So the format will be Matt speaking for around 30 minutes, but we're not keeping to time. And this will leave us with some questions, with some time for questions to take us to the end of the hour. So please keep yourself muted until the end when we have plenty of time for questions, and feel free to use the chat function if any sort of questions come to mind while Matt is talking, and we can go through the questions on the chat afterwards. So without further ado, I'll pass you over to Matt.
Hi everyone, I hope everyone can hear me. I was having a few technical issues before I started presenting just before, so Gareth and Anders can attest to that. I promise I am sort of technologically savvy, but you know, hopefully this all goes to plan. But thank you to Gareth and Anders for inviting me today to present on this topic. As mentioned, I am a researcher in exercise physiology. I am an accredited exercise physiologist in Australia, which is the equivalent of a clinical exercise physiologist in Canada and the US. And I have a particular interest in using exercise as a therapeutic tool, particularly in those individuals with typically end-stage conditions or chronic medical conditions. And my PhD was actually in exercise before liver transplantation, and how we can use exercise to try and improve an individual's prognosis before surgery. But I've taken on I've taken on a bit more than I think I can chew, and I'm going to be trying to cover before and after liver transplant in this presentation today. So I reckon we get straight into it. And yeah, if there's any questions at the end, more than happy to. And if you've got any questions afterwards as well, my contact details are below. So the presentation, I'm going to sort of keep it structured, and really the start of it's going to sort of outline a few of the key issues before and after liver transplant relating to frailty, physical inactivity, and associated comorbidities. Highlight the current evidence demonstrating the importance of engaging in exercise and physical activity before and after liver transplant. Offer a few practical and incredibly general exercise and physical activity advice for practitioners who may be working in the field or they may be starting to work in the field, and just highlight some of a few key areas that researchers are really starting to look into towards the future. And then at the end, we'll just have some time for some questions. So this will be fun. So We all know that liver transplant is the definitive cure for advanced liver disease. And based on certainly the latest evidence, the number of liver transplants performed worldwide is in fact growing. So for example, the centre, the Queensland Liver Transplant Service in Queensland, Australia, where I was previously at before I moved to Adelaide, had increased their liver transplants by about 50% over the past 10 years. So it really shows you that there is quite a number more transplants occurring. However, what we do know is that there is a mismatch between the number of organ donors and eligible candidates awaiting liver transplant. And it's not necessarily uncommon that some patients may spend months or even years waiting for a new liver. And this is fairly common across all solid organ transplants. When we look at evaluating an individual's condition, the model of end-stage liver disease, or the MELD score, is used. And I'll refer to the model of end-stage liver disease as the MELD throughout the presentation, which actually now incorporates sodium within the score. But essentially, the higher the MELD score, the greater risk of mortality on the transplant waitlist. However, what is of increasing interest to the healthcare team is that there's a variety of additional risk factors that I guess may contribute to complications on the waitlist, but also complications that can occur during and after the surgery, which include a variety of both modifiable risk factors and non-modifiable risk factors, such as increasing age. We know that candidates over the age of 65, there's an increased chance of waitlist mortality, and as well there's a decreased risk in the odds of actually getting a transplant. Decrease in physical function and strength, a decrease in cardiorespiratory fitness, poor nutritional status, body composition changes, so decreases in our muscle or the moving parts of the body, and increases in fat mass, as well as non-liver related comorbidities such as increased body mass index or BMI, as well as established or suspected cardiovascular disease, diabetes, and even chronic kidney disease. And specifically for the next few slides, what I'm really going to stick to is the risk factors that are actually highlighted or bolded in particular. So if we have a look at physical function and muscle strength, which is what I mentioned before, the evidence suggests that around 17 to about 50% of people living with advanced liver disease are what's characterized as frail, which is an increased vulnerability and global physiological decline. And what's interesting is when you have a look at frailty in advanced liver disease, which has really been driven by the fantastic research conducted by Professors Lay at the University of California in San Francisco, you'll see that individuals who are actually frail using the Liver Frailty Index, which is captured using some basic objective measures of function, how fast you can walk, how many times you can get out of a chair, as well as your grip strength as well. What they've found is that there's a significantly reduced probability of survival on the wait list compared to those who are not frail. Another factor to consider, as I mentioned before, is an individual's level of cardiorespiratory fitness, which is typically defined as the maximum amount of oxygen you can bring into your body and use during exercise, or what's coined VO2 max or VO2 peak. And if you're in the exercise world, there's often a bit of a debate about what that is. But typically this is quantified using what's called a cardiopulmonary exercise test, which you can see on the screen there, or other types of exercise tests some of you may be more familiar with, like a 6-minute walk test or an incremental shuttle walk test. And when you have a look at the plot on the screen, what you'll see is that survivors after liver transplant actually have a higher level of cardiorespiratory fitness compared to those who do not survive on the liver transplant. Finally, another factor to consider is the impact of muscle mass on outcomes before and after the liver transplant. Now, there are a few caveats to this about how past studies have actually used the term sarcopenia, with most focusing typically on muscle mass, but it's clear that sarcopenia, which is actually characterized by loss of muscle mass, strength, or function, impacts around 22 to upwards of 70% of all liver transplant candidates, with this particular study showing that the probability of survival is lower in someone that has sarcopenia, which is indicated by the dotted lines, compared to someone who does not have sarcopenia. When you put all these factors together, it really becomes increasingly clear that frailty, low cardiorespiratory fitness, and sarcopenia appear to increase the risk of complications before and after surgery. And this diagram does a really nice job of summarizing this relatively complex interplay between these factors, as well as additional factors, which I haven't really talked too much about, like nutritional status, and how these impact upon the overall outcome for a patient waiting transplant. However, while I am, I guess, painting somewhat of a dim picture, we know that engaging in regular exercise and physical activity has actually shown to improve frailty outcomes, increase cardiorespiratory fitness, as well as improve muscle size and function in a variety of cohorts, both individuals who are healthy, as well as individuals that have chronic disease. So although these are known risk factors, they are potentially modifiable, which can have the flow-on effect to potentially improve outcomes before and after liver transplant surgery. But what's also interesting is that there's definitely room for improvement in this cohort, as a large proportion of candidates actually don't engage in regular exercise and physical activity. And for example, in this study by Dunn and colleagues, which was conducted a few years ago, they actually tracked physical activity using an accelerometer, and they found that individuals with advanced liver disease were on average getting around 3,000 steps per day. Now, for the most part, most people would be aware with the whole 10,000 steps goalpost. There's actually new evidence to suggest that this might be a little bit high, but regardless of that, it seems that this particular cohort are really not getting a lot of physical activity. Another interesting point is that when they actually divided physical activity data up into the various intensities, so vigorous intensity, moderate intensity, as well as light intensity physical activity, around 75% of an individual's day was actually spent sedentary, with about only 5% of the day participating in moderate and vigorous physical activities. Now, while this doesn't seem great, I would actually look at this more as an opportunity to try and shift people from being less sedentary. So trying to minimize that 75% and even shift towards engaging in light physical activities, which we know from epidemiological evidence still has very clear health benefits. Shifting to after the transplant surgery, there's still a number of challenges that recipients face, notably increased time spent inactive, prolonged bed rest, particularly if there's been complications within the hospital, as well as the impact of some of the medications that are used to try and suppress the immune system. For example, typically within the first year, there's a rapid increase in body weight, upwards of, in that this can occur in around 16 up to 65% of recipients actually do become obese, which is characterized by that BMI of over 30. And this typically occurs within the first year after transplant. There's also skeletal muscle reduction and overall weakness, particularly if complications actually arise during surgery or in the intensive care unit, meaning that there may be a prolonged stay in hospital. There's a decrease typically in exercise capacity or VO2 max, as I mentioned before. There's a significantly increased risk of developing the metabolic syndrome, which is this collection of conditions, including obesity, elevated blood pressure, I suppose those unfavorable changes in blood lipids, as well as insulin resistance. There's also an increase in cardiovascular disease, the onset of cardiovascular disease, as well as risk factors attributed, as I mentioned before, as well as an increase in overall levels of fatigue. And speaking specifically to physical activity, fortunately though, in most cases, these levels will typically return back to pre-transplant levels. However, the level of recovery may actually be dictated by an individual's experience prior to transplant, as well as complications that actually may arise during the procedure and after the procedure. For example, If you have an individual who participated in high levels of physical activity before transplant and they don't experience complications after surgery, they may recover to a near normal or normal levels of fitness after the surgery, which, as you can see at the top there, by the little person sort of running and the green arrow going towards it. However, if we go down to the red arrow, this may actually be the opposite for someone who has not only experienced complications after surgery, but may not necessarily be motivated or unable, or is uneasy with starting to commence exercise coming off the back of some complications. What we do see, though, is that these physical activity values may gradually return back to pre-transplant values after surgery, but it still remains, it's clear on average that the amount of physical activity performed each week still remains below the recommendations of about 150 minutes of moderate physical activity per week. And this seems to be lower in those who may actually experience metabolic complications after liver transplant, which is what you can see to the left hand or down the bottom of the screen, where the recipients who have a diagnosis of the metabolic syndrome engage in around about 80 minutes of exercise per week, and those without the metabolic syndrome engage in about 110 minutes per week, which on average is still significantly lower compared to those recommended guidelines. So while the values may, I suppose, go back to pre-transplant levels, these levels are still potentially lower than they should be. However, and again, similar to before, while these values may remain, I guess, lower than expected, there is an opportunity to try and promote exercise and physical activity among liver transplant recipients. And it's well established from other cohorts that engaging in regular exercise and physical activity has shown to increase exercise capacity, reduce the onset and severity of cardiometabolic complications, improve body composition, so increasing muscle mass and decreasing fat mass, and as well as decreasing fatigue. So while it's well and good that I suppose have tried to paint a positive picture for exercise and physical activity before and after liver transplant, it's equally, I guess, if not more important, to actually provide a justification around the rationale for using exercise in this setting. And if you go onto PubMed, which sadly is actually my home screen on my computer, I probably need to start changing that to make it a little bit more appealing. It's abundantly clear that exercise or the interest in exercise, physical activity and liver transplant is growing significantly and rapidly. And it's even continuing to rise amid this global COVID-19 outbreak, which I guess could partially be explained by some of the very cool and very cutting edge studies that are starting to take place, which I'll talk a little bit more about later on. And I guess the second thing what's really fantastic to see, it's not only one country doing all the heavy lifting, but there's really a global movement in this space. And certainly researchers from Canada, the United States, and the UK are conducting some very innovative work, revolutionizing how we use physical function screen as predictors of outcomes for liver transplant patients, but also around exploring the use of exercise in this setting. That's not to say we're not holding our own in Australia, with some of our centres actually conducting very similar research in these particular areas. That being said, the majority of the reviews that are currently out there are very much driven by researchers in the Northern Hemisphere. And I'm going to present some of their findings to the group, summarising the evidence for exercise training before and after liver transplant, and hopefully paint a positive picture for exercise and physical activity in this space. When you have a look at the evidence before liver transplant, Williams and colleagues from the UK conducted a really nice summary of the current evidence for exercise training and how this actually may impact upon frailty outcomes in this cohort, which was only published a few years ago. However, as you would see by my trusty PubMed graph that I presented before, this research is actually growing at an exponential pace, although the findings from this review are still very relevant. And I definitely encourage those interested in the articles to have a look at the article. It's really well written and it provides excellent summary tables of the current evidence about what I'm about to present. So when they gathered all the evidence, there was 11 studies in total, with 5 of these actually being randomized controlled trials. So patients got randomized to an exercise group, or they got randomly allocated to a control or your usual care group, which is, I guess, the gold standard of how you determine whether exercise is actually effective or not. What was clear from the findings, or from the majority of studies conducted in the major findings from this, what you'll see is that the majority of patients that were enrolled in these particular studies had compensated disease. So they were typically asymptomatic of liver-related comorbidities, although there was a small number of individuals who were actually listed for transplant, which is good news. And typically the exercise was typically prescribed at a moderate to vigorous exercise intensity, at a rating of perceived exertion of around 11 to 15. For those who are common with this particular term, this is typically around that moderate trending towards vigorous exercise intensity. So that, I guess, if you were to walk next to someone at this intensity, you'd still be able to, I guess, maintain a conversation with that person, but you wouldn't necessarily be able to sing a song to them. It was also really interesting to note from these findings that the major type of exercise was typically aerobic training. So doing things like walking or cycling on a bike, or even cycling on an ergometer, or aerobic plus resistance training. So there was those things plus doing bodyweight exercises or lifting external weights. And finally, one of the other major findings was that the majority of these interventions were typically supervised by trained personnel. So by physiotherapists, by medical staff, and by clinical exercise physiologists. And it was typically conducted within a hospital setting. The major findings from the review was good news for exercise, being that there was no serious adverse events reported from exercise training. Although it's really important to note that these studies weren't necessarily designed to actually evaluate safety. But this is good news, particularly in the past, there's actually been a little bit of hesitation to prescribe exercise in this cohort for a variety of reasons, mainly relating to some of the liver-related complications that can actually arise when the disease becomes decompensated or the severity of the disease increases. Another important finding from this particular study was that adherence to exercise varied significantly, ranging from very small amounts of adherence of 6% all the way through to 100% adherence. So it's pretty challenging to sort of take some of these findings because, a large proportion of people may not have actually been adhering to the exercise. However, this actual adherence, speaking to this again, may have impacted upon some of the findings. We need to actually adhere to exercise to improve cardiorespiratory fitness, improve muscle strength, and improve muscle function. And this was actually noted within the review, which was great to see, with some of the studies actually finding improvements in exercise capacity and muscle strength, and quality of life for that matter, whereas others didn't actually find any significant changes. Finally, an important, I suppose, finding from this, that although exercise was safe and had a varied response in some of the outcomes that the researchers were interested in, none of the actual studies reported information around some of the clinical complications before and after the actual transplant surgery. And this is important because ideally we want to try and be using exercise to try and improve the individual's risk and therefore mitigate these post-operative complications that may arise. One particular study that I'll point out that was actually published very earlier this year, so it's brand new, hot off the press, also reflected some of the findings of this review as well. As far as I'm aware, this was the largest RCT to date evaluating the efficacy of exercise training, notably resistance training, to improve outcomes in patients with frailty who had a diagnosis of cirrhosis. And you remember that this is important as pre-transplant frailty appears to be associated with poorer waitlist and post-liver transplant outcomes. The intervention lasted about 12 weeks and was delivered in a home-based setting, which is important. But there was a lot of infrastructure put into this study. So patients had weekly follow-up calls, as well as an exercise video. And participants were gradually told to progress their, do some steps, try and increase their steps every week by about 500 steps, and perform the resistance training on about 3 days per week. And overall, again, sort of reflecting some of the findings from Williams' nice review article, was that the intervention was safe. So there was no adverse or serious adverse events, although the adherence was actually quite low, with only around 14% actually doing the intervention 3 times per week over the course of the intervention. One of the interesting findings as well was that there was actually no significant improvements in the outcomes that they were assessing, including this liver frailty index, what I mentioned before, as well as the average number of steps and quality of life. So whilst it was, I suppose, summarized that exercise was safe, its effectiveness may be questionable in this particular case. However, what I would do and encourage people to do is have a read of the article and have a look at some of the finer details associated with this article, which is sort of beyond this forum, as the authors do an absolutely brilliant job sort of delving into the data and really trying to identify why this intervention may not have worked and why they might not have actually seen an effect, as well as what to do in the case that you're planning a study in this particular cohort, particularly around the use of wearable devices. Moving on to after liver transplant, there's actually been a few reviews now that have done a fantastic job of summarizing this evidence. And again, I think I'm maybe the only one from the Southern Hemisphere here. So everyone in the Northern Hemisphere, you guys are doing a great job summarizing all this information, particularly those in the United States, Canada, and the United Kingdom, who are really driving this research forward. Although I will subtly hint that there may be some research coming out of Australia in the coming months, so watch this space. Again, I'm going to focus on Felicity Williams' review, which does a fantastic job summarizing this evidence after liver transplant as well. What the evidence showed was that there were 7 studies, with 3 studies being randomized control trials, although I'd imagine there's been a few more studies that have been published since this was actually published. And in general, the majority of studies enrolled patients at around that 6-month post-transplant mark, although there was one particular study that enrolled patients around the 3-week mark after transplant. And similar to the pre-liver transplant literature, the exercise was generally prescribed at a moderate to vigorous and to somewhat high exercise intensity, with researchers opting typically for a combination of self-reported intensity like rating of perceived exertion, or using heart rate metrics, given that this particular group don't necessarily need that a medication to stop some of the liver-related complications that may arise that typically happen in the pre-transplant space. And again, similar to the preoperative studies, the majority of evidence was typically aerobic exercise or a combination of aerobic and resistance training, and typically conducted under supervision at a hospital or in a healthcare setting. Again, there were some positive signs for exercise here, with no exercise interventions reporting any serious adverse events or adverse events, although there are some, again, caveats along with that, given that the studies weren't necessarily designed to evaluate overall safety. There was a little bit better adherence, although this was typically not often reported. But another positive finding that came from this I guess, summary of evidence was that the majority of studies reported significant improvements in exercise capacity and muscle strength, with some studies actually reporting a positive change in quality of life, whereas there were a few studies that didn't. However, on this particular last point, it's really important to, I guess, explain the caveats to this, in that some of these studies actually used a behavioral change intervention, like using counseling. So I guess it's hard to definitively say that exercise alone led to these improvements in quality of life. An interesting study that was actually embedded in this particular review was out of a Spanish group who conducted quite a large 24-week exercise intervention after transplant. And the really cool thing and really interesting thing about this study was that they implemented moderate to high intensity exercise using a combination of aerobic and resistance training, as well as some balance training. And overall, particularly the resistance and aerobic intensity was at intensities that were done typically higher compared to a lot of the other studies included in this review. And the major findings from this particular study was that exercise significantly improved exercise capacity and muscular strength, as well as components of quality of life. And importantly, and similar to what the previous reviews I've talked about have summarized, is that there was no adverse events associated with the intervention, but promisingly, there was about a 94% adherence rate to the prescribed exercise. So I guess from this, we can say for the right individual engaging, or I guess for the right individual at the right time, engaging in exercise at higher intensities may be a useful tool to keep in your exercise toolkit or your exercise arsenal, which is really important. We know that exercise typically performed at higher intensities seems to confer greater benefits compared to those performed at lower intensities. Now that I guess I've discussed some of the evidence supporting the efficacy of exercise before and after liver transplant, I really wanted to use this opportunity to disseminate some of the, I guess, incredibly useful resources that are available if you are working with someone in this particular cohort. And firstly, I definitely recommend reading the article by Tandon and colleagues, which is the top article, which provides a really fantastic overview of the current evidence and practical recommendations for not only evaluating an individual before transplant or with cirrhosis, but also prescribing exercise in this cohort. And it does so a really nice job bringing all the evidence together in a way that's meaningful and really spells out for someone how to actually use these tools and prescribe exercise in this cohort. Another excellent resource is the joint position statement from the Canadian Society of Transplantation and Can Restore, which does a fantastic job harmonizing the large amounts of literature pertaining to all solid organ transplant candidates and recipients. I mean, I'm just doing a small presentation on just liver transplant before and after, whereas this particular statement summarizes all solid organ transplants. And it provides some general recommendations around the evaluation and exercise prescription, not only just in adults, but also in a pediatric population as well. So there's one thing I'd really want you to have a look at from this presentation. It's these two particular resources. Although exercise appears to be safe, as we've talked about before in some of the systematic reviews I've presented, it is still recommended to conduct some type of pre-screening to evaluate not only liver disease related concerns, but also some of the concerns that are typically, I suppose, identified before engaging in exercise, like issues to do with the heart and lungs, as well as in this particular case, frailty, as well as musculoskeletal and other safety concerns. And this is important as the majority of studies, I guess, in this cohort actually exclude individuals with high levels of disease severity, as well as those with what's called primary and secondary variceal prophylaxis. So all the studies that I've really talked about before have done a really good job of screening typically higher risk individuals. So if you are actually going to be prescribing exercise in this higher risk cohort, it is definitely recommended to do some type of exercise pre-screening. In this particular table, as part of that particular article, the Tandon et al. Article I presented before, does a really nice three-part process, which is specifically titrated to individuals with cirrhosis, with recommendations about how to proceed with exercise, which is a fantastic resource. And that being said, in most cases, if you have a patient who is asymptomatic, who's wanting to undertake low to moderate intensity exercise, such as going for a brisk walk, it's generally okay to participate in this level of activity without necessarily having to engage in some type of pre-screening, as actually engaging in pre-screening may actually be a burden to engage in physical activity. So it is important to realize that there are people that will need pre-screening, but there are people that may be healthy enough to actually go ahead and prescribe a low to moderate intensity exercise program. In addition to the screening, it's also really important to conduct some type of pre-training assessment to evaluate cardiopulmonary safety concerns if they're suspected, but also establish exercise intensity and to evaluate the efficacy of the intervention. So there's a ton of tools out there for the clinician, and the joint position statement from the Canadian Society and Can Restore does an awesome job summarizing all these tools and information you can use. But I guess one of the key things is that you need to use the tools wisely, so you're gathering not only meaningful data, that's not causing excess burden on participants, and is actually going to assist with your exercise prescription. A lot of these tools range in complexity and can be very cheap or very expensive, particularly in the case if you're doing cardiopulmonary exercise tests, which, you know, some of these metabolic carts can cost upwards of $100,000 Australian, which also requires a high level of technical training to conduct the test in a reliable and meaningful way. I think the main thing I want you to get from this slide is that you don't necessarily want to do every single outcome assessment, but be choosy with your tools that's going to inform your prescription, that are feasible to perform in the setting that you're working, and you as the assessor can perform them in a way that's repeatable to actually ensure the efficacy of your intervention. So before exercise as well, we also need to spend some time evaluating a patient's readiness to participate in exercise. And there's a variety of frameworks available to assist in this process. And by no means am I a behavioral change expert, but these are some nice tools that you may want to consider when looking at prescribing exercise in this cohort. So motivational interviewing is an incredibly useful tool to assess exercise motivation and readiness, highlight the importance of change, as well as building confidence and preemptively identifying any potential barriers for exercise. And another useful and simple tool is the 5 A's intervention to promote physical activity. And this can actually be done in a relatively short time frame, particularly if you've got that busy clinic, you're in a clinical context where you may not actually be able to spend a lot of time working with your patient because you're back to back with patients all day, or you're doing clinical notes or whatever it is. But in the initial instance, when you are conducting this 5 A's framework, asking about an individual's current physical activity, so ask, and if required, the next step is to advise about the benefits of participating in exercise and physical activity. The next step is to then assess the readiness for change and willingness to enroll and participate in an exercise program. And after that comes with assisting in developing the actual exercise plan, as well as setting goals for that particular plan. And finally, it's important to also preemptively arrange follow-up to ensure accountability and monitor any changes that may require a reevaluation or replanning some of the individual's goals. I suppose one of the big points I want to get from here is that while there may be systems for pre-screening, there's some systems for guidance for performance assessment and readiness for change, the actual exercise prescription should always be evidence-based and co-designed. And we need to really steer away from that one-size-fits-all approach. And this not only ensures that the prescription is context-specific, but it also makes sure that it's user-centered, which empowers patients to participate in a program that is not only appropriate for them, but is also responsive to their needs. And so when you're designing programs, as a general guideline, following the FIT principle, so some of you may or may not be familiar with this, so things like frequency, so how often you perform the exercise per week, intensity, how hard do you perform exercise at, time, how long is the duration of exercise, the type of exercise, so what mode are you using, are you walking, are you running, are you cycling, the overall exercise volume and progression are two sort of additional add-ons to the concept of the FIT principle. And volume really is about how much exercise is performed throughout the week, and as well as the concept of this progression, which describes how exercise will gradually be increased over time, whether this is intensity or frequency or time. But in some instances, I guess progression is important to realize that there may actually also be regressions as well. So particularly if you have patients that are a little bit sicker, or for example, they increase levels of fatigue, progression can also become regression. But when you have a look at the general guidelines for prescription in cirrhosis, it's really important to realize that these are guidelines. And I really want to emphasize the importance of really co-designing your exercise programs and really making sure that they're individualized. So, there may be some people out there that are able to easily meet these exercise prescription guidelines, and others may be flat out getting out of bed because they're incredibly fatigued. And additionally, some patients may have complications that may limit their ability to perform some of the exercises. So it's really critical to tailor your exercise prescription. But as a general rule, it should be aimed to do aerobic exercise, so that walking and cycling at a moderate intensity, ideally done on most days. But you need to start with what an individual can do rather than trying to meet these guidelines straight away. And this will typically be built up over time, and it can be as simple as doing 1 minute of exercise at a moderate intensity, having a break for another minute, and doing this for 5 minutes. With the emphasis though on gradually trying to increase the amount of exercise you're doing, the amount of time that you're doing exercise, and potentially at points in time looking at changing the exercise intensity. The exercise mode also needs to be tailored to the individual's preference for exercise. So if your participant enjoys walking, then prescribe walking. If they don't own a cycle ergometer and you want to do cycling with them, you may have to go back to the drawing board and have a rethink about how you get an individual to prescribe to do exercise. And with resistance training, when we look at this particular guidelines, the recommendation is to do on 2 days per week at least, on non-consecutive days. So try to have a day or two between when you do resistance training. This combines multi-joint exercises as well as single joint exercises, with a real emphasis on correct technique, and that's really important. And typically, if your individual can do 3 sets of 15, and they can report that this is pretty easy, then you probably need to have a look at how do we make this a little bit harder so that we can use progressive overload and ensure that there's you're getting therapeutic dose of exercise. The exercise that this individual is doing is actually having an effect. And there's also recommendations for flexibility and balance exercises, which is the latter is particularly important, particularly if you have someone that's frail, with the aim to really perform these exercises on 2 days per week. And for the most part, the pre-transplant guidelines are very similar to the post-transplant period, which the general recommendations have been provided by the Canadian Society of Transplant and the Can Restore Joint Position Statement, and do a nice job of sort of succinctly summarizing these together. And so looking at the frequency, 3 to 5 times per week at a moderate intensity, aiming for at least 30 to 60 minutes with the goal of achieving 150 minutes, and doing aerobic or a combination of aerobic and resistance training. Now, the only caveat here, one of the caveats here, is that in the initial post-operative period, in the case that there may also be medical concerns, it may actually limit unsupervised exercise. It's encouraged to perform supervised exercise, particularly in this initial period, whether this is in an outpatient setting or even some of the changes we're seeing in use of technology. So using remote monitoring technology can also be useful here. Additionally, and as a general recommendation, exercise programs prescribed around that 6-month mark typically can be done in an unsupervised setting, and this can be done often at home or in other fitness centers and those sorts of settings. However, it's really important to realize that there's a variety of factors why you may want to do this. And I should really, I suppose, caution this advice is that if the individual you're working with is very new to exercise, it's important that supervision probably needs to happen in the initial instance to make sure the exercise is safe, it's done correctly, and there's good adherence in the short term to maintain for the long term. I guess the final part of this presentation is where to from here, and this is some of the cool research and cool applications that are really starting to come around. And certainly when we have a look at what is available pre-transplant in cirrhosis and after transplant, the Wellness Toolbox is a free resource, particularly prescribed for individuals with cirrhosis. So if you're looking for something that can be easily administered and can give you some guidance on how to prescribe and assess exercise, I definitely recommend that as a resource. It's free and free to use, as well as the REFIT program, which the World Transplant Games Federation have worked with partners across the world to really bring together some of the best minds to prescribe it. I suppose a semi-automated exercise platform, not only with exercise, but around dietary modification and other lifestyle factors, which is available for use as well. So it really brings me to the second point, which I guess I should probably touch on in the first point, is that I think one of the big things that we're seeing and what I suppose COVID-19 has really shone to light is improving exercise availability for patients wherever they may be. Particularly what we have in Australia, and it's probably very similar to what is in Canada and the US, is that there's a vast landscape, and it's often quite difficult for individuals to actually get to centres. So home-based technology is really starting to take off. And this particular study, which has recently just been published, is a smartphone application designed in the initial preoperative phase, particularly for liver transplant candidates. And this particular study sort of showed that the usability is quite good, and that individuals do tend to increase their physical activity by participating in the actual study itself. So some really great ideas happening. And, who knows from here, if this is happening in 2021, it's crazy to think what's going to be happening in 2022 and 2023. Another factor to consider is, some of the wearable devices that are really starting to take the market by storm. Wearables, I suppose, offer a really unique aspect to how we can prescribe exercise. Funnily enough, I had a patient the other day said that, wearables aren't for me. I got it on Christmas and I returned it on Boxing Day. And so, these types of devices aren't necessarily for everyone, but they can be a useful tool, and particularly one that has come out recently, which is this personal activity intelligence, or PI, which is a freely available app that can be synced to various smart watches that uses biometric feedback, such as heart rate, to provide a single unit of measure, with the overall goal of trying to achieve 100 PI in a week. Now, the beauty of PI is that it regulates. So in that, it progressively becomes harder to actually achieve 100 PI. And for example, you have instances where you have significant amounts of fatigue or those sorts of things. It'll actually sort of down titrate your exercise. So it sort of moves back and forth based on biometric data, which can be a little bit complicating in the pre-transplant phase, particularly if people are taking beta blockers. It's evidence-based, so it's derived from the Hunt study, which is a very large Norwegian-based study. And it really, I guess, tries to answer the question, am I doing enough exercise? With a very simple goal is, if I am meeting 100 PI at the end of the week, I am doing enough. If I'm not, I probably need to do a little bit more. Now, the caveat to this is that it still yet hasn't been evaluated in this particular cohort, but certainly it's something to consider for the future. Another thing to think about is, optimizing exercise dose. How long, how hard, how often, and what type of exercise to elicit these positive physiological improvements. And this is a really interesting study, and some of you may have heard of the term exercise snacking, where in this particular study, participants, and these are healthy individuals, did 3 by 20-second intervals, did it 3 times a day, and did that 3 times a week. And so over a 6-week period, they only did 54 minutes of exercise, and actually found that this led to significant improvements in cardiorespiratory fitness. So 54 minutes exercise over a 6-week period. Who knows how this could be translated in this particular setting, but it does beg the question is that, when research is really starting to take off in this particular space, our job is to really start to think about how we can use this information within our clients and our participants, but how we can design studies in the future to try and optimize and really identify the best therapeutic dose of exercise. How low can you go to get the best bang for your buck? Other things to consider is really around the size of the studies to date. Typically the study sizes are quite small, and often, particularly in the pre-transplant space, there's not a lot of post-operative data that's used. And so really some of the questions is really, does large-scale RCTs, and they are starting to be, be undertaken, as you can see in the clinical trials down the bottom. There's about 34 studies that are currently being evaluated. Does exercise before transplant actually improve outcomes after transplant? And this is a really important question that I know there's a growing interest around. I think one of the really important things is long-term exercise. The majority of the studies, particularly after transplant, were conducted up to 6 months, with the exception of one particular study, which was done to 1 year. So, what happens after that year is really important to consider. And another important question, which there's some interest, particularly in this group, is around healthcare utilization. Does exercise and sport and physical activity actually improve the utilization of healthcare finances on more of an economic scale, which is really interesting. And finally, I guess leading to the why we're here is that it's really important, and it'd be really good to see, is that we need to have a look at evaluating the impact of organized sports, so the domestic and world transplant games, what impact that has on transplant recipients' health and well-being, as well as an economic impact. So these are particularly big picture recommendations, and whether this happens in the next year or next 5 years or next 10 years, I'm not quite sure what that trajectory would be, but certainly us here today, I think, is a really positive step in the direction. And that's the end of my presentation. I welcome any questions or comments or criticisms or whatever it is. But thank you again for the opportunity, and looking forward to chat. Thank you.
Thank you very much, Matt. It was very, very interesting. So we have a couple of minutes left for questions and comments. So please, if you just want to unmute yourself or just write the question in the chat, and I will try to prioritize the questions if there are many questions. So anyone?
If I may jump in there, Anders,
Please, Liz.
Yes, so my name's Liz Schick. I'm 23 years post-liver transplant, and I work with Anders. I'm the secretary of the World Transplant Games Federation. And before my liver transplant, I was a fitness instructor and live in a ski resort, so I was very active. And I was lucky to feel good when I went into transplantation. I was actually going to the gym 3 times a week before transplantation. And I needed a transplant because I had epithelioid hemangioendothelioma. My liver functioned perfectly, but I did have tumors growing around my blood vessels. And most definitely, when I see other friends that have had transplants about the same age as myself, etc., it was so important to my well-being, mental well-being, and for the getting better afterwards. I looked upon the whole thing as like getting ready to run a marathon. And that is now what I often say to people who are waiting for a transplant, is think of it, whatever, physical state they're in, think of it as your marathon, because it's really up to you. You have to prepare for it, whatever state you're in, because you're putting all your pennies in the right place. And yeah, lovely presentation. Thank you very much.
Oh, thank you. Yeah, it's definitely, and I suppose, where I was working with individuals before transplant, that was some of the things that we were reporting as well. So, the marathon example is a perfect conduit to, I guess, sell the importance of exercise. Typically, you wouldn't necessarily prepare for a marathon by doing nothing. So preparing yourself as best as you can before the surgery, and it's one of those procedures that is challenging, because you don't know necessarily when you get a call and then you receive the transplant within a matter of hours. Unlike some of the work that I'm currently doing now, which is typically in the cancer space, where typically patients have a scheduled date. But I 100% agree, anecdotally as well, working with these individuals, and as you mentioned as well, Liz, you feel better physically, feel better mentally. And I think those sort of reports are really important to really drive the research forward. Too long as researchers, we typically know what's best, but that's just not the case. You need the lived experience of someone who's gone through this to help us design these types of programs moving forward. But thank you for your comment. I really appreciate it.
Thank you.
Thank you very much, Liz. And right now we have 2 people in the line. So Cora asked a question regarding physical activity for kids, liver transplant kids. So have you come across any results on that?
Yeah. So I know that I have. I can't exactly recall the exact studies. I know that there's quite a prominent researcher in physical activity, and before and after, typically after liver transplant and kidney transplant, Dr. Patricia Painter, who's done a fair bit of work in this space. And I'm fairly sure she has 1 or 2 studies that have evaluated the efficacy of exercise after transplant in pediatric liver transplant recipients. I'm not currently aware of any exercise interventions before liver transplantation. Typically, it's one of the, when you have a look at the inclusion-exclusion criteria, typically they recruit adults. And so I could be wrong, but I can't think of any studies that have done beforehand. But certainly in the post-transplant period, I believe that exercise seems to be safe and seems to result in some improvements in physical function and quality of life. But I don't know about the robustness of the data, you know, how many studies have actually done it. So it's a good question. Maybe I'll do a pediatric presentation next time and go from there.
Good.
I hope that answers your question, Cora. Sorry.
Thank you very much. I think we have room for one more question. So Peter has raised his hand. So please welcome Peter.
Thank you, Anders. Thanks, Matthew. Great presentation. Lots of information, still confirming the general line. One thing I noticed is that you mentioned some research that gave information on the adherence to programs, and it varied rather much, from even 0 to 100%. Have you any information on why this variation is so big? Because that tends to point to motivation or whatever blockades that are maybe within certain patients to go to sports. It'd be very interesting to know why. Why is that adherence so low? Any information on that?
Yeah. So there's a few reasons, and each sort of study, I suppose, has a similar flavor in that when you have a look at the studies that are typically done unsupervised, typically the adherence to exercise tends to be a little bit less, actually quite a bit less compared to those programs that are supervised. So that typically means what you've got someone there sort of, on the whip, sort of on the bike or whatever it is, sort of doing your exercise, whatever it is. And, you'll have people like Liz, for example, who's motivated to do exercise, but not everyone is intrinsically motivated to do that. There are some, in that one of the studies that I presented around the outpatient program, that probably the biggest liver transplant candidate exercise training study to date, where there was about 14% adherence to doing it 3 times per week over a 12-week period. One of the limitations they said with that was that they had a fair bit of challenge with the wearable devices to actually assist with trying to improve aerobic fitness through increasing step counts. And so they thought that that may actually be one of the reasons why they saw potentially poor adherence. I think though, as we're becoming more engaged with technology, and as I mentioned before, what's really come to light is, how can we embed technology within services and within how we prescribe exercise to try and improve adherence. And I think some of the work that's being done at University of California is really trying to answer some of those questions, building applications, using nudges, using other biometrics to try and improve physical activity and overall health. Another potential reason associated, particularly pre-transplant, is levels of fatigue and changes in physical and clinical status. Often what you'll typically see, and what I've seen to date with experience, is that if people experience some complications associated with the condition, they'll typically not participate in exercise. And in some instances, after transplant as well, if someone has acute rejection, doing some moderate to vigorous physical activity is often not necessarily recommended, which can again affect adherence to those sorts of things. So I think that the answer is multi-component, and I think that I wish I could give you a one simple answer, but I think there's too many components to try and discuss.
Well, I was just asking to see if you have any more information. The funny thing is that you mentioned a number of research projects that skipped off after 3 months or 12 weeks. And the funny thing is that is exactly the time you see in other interventions, for instance, people stopping with smoking or trying to lose weight at the beginning of the year. Generally by April, they have gained weight and are smoking again. So that 3-month period is generally the period in most, it looks a little bit like people falling in love. They tend to be completely excited for 3 months and then it wears off. So
it's called the honeymoon period.
Yeah, I don't know where it comes from, but it strikes me there's a certain coincidence by that 3-month period. And that's why your recommendation to go for longer period research might be very important, because then you might get some information on why people, although they know it is good for their health, they even might improve their lifespan, and still they drop off. We've seen the same thing in the Netherlands with the COVID intervention. In the beginning, everybody started walking, and after about 3 to 4 months, it dropped off. So there might be something there. Might be interesting.
Yeah. You know what? I would love a funder to give me $1 million to run a one-year randomized control trial. I'll be praising to the research grant gods for that one. But that typically those 12-week interventions are often designed around the fact that we can typically get meaningful improvements in physical fitness in that time. But also there's often like a large cost associated with these types of interventions. So I think, moving forward, as technology becomes better, it's also going to reduce the amount of cost associated with supervision. And if we're getting better at this, then hopefully that'll improve as well.
Yeah. I understand the problem. We have the same over here. Good luck.
Good. Thank you very much, Peter and Matthew, for this discussion. The time flies, and we have just passed 1 o'clock, so Swedish time at least. So and 1 hour for this seminar. So on behalf of the World Transplant Games Federation, Gareth and I would like to thank you, Matthew, for this wonderful presentation and give us an insight and introduction to physical activity, pre and post liver transplantation, and a little bit in general as well, right? So and all the questions and answers. So thank you very much, and hope to see you in a couple of weeks from now.
Thank you, everyone.
Thank you.
Thank you, everyone. Thank you for having me.
Thanks, Matt. Bye.